Well, hello, everyone, and welcome to this edition of the Global PAD Impact Awards brought to you by the Global PAD Association. We are here to honor an individual who has redefined patient advocacy in the field of peripheral artery disease. The Global Patient Champion of the Year Award for 2024 recognizes exceptional dedication, unwavering commitment, and transformative impact in the lives of PAD patients worldwide. Our recipient has demonstrated remarkable leadership in supporting online communities, raising awareness for PAD, and fighting healthcare disparities across the globe. His tireless efforts have empowered patients, influenced policy changes, and fostered innovative solutions to improve the quality of life for those affected by PAD and its most advanced stage, critical limb ischemia or critical limb threatening ischemia. This champion's work extends beyond borders, touching lives across the globe through real-time support in online communities and facilitating limb-saving care. His personal sacrifices and long-term commitment have truly set new standards in patient-centered initiatives and holistic care advocacy. So it is with my great honor to introduce the winner of the Global PAD Patient Champion of the Year for 2024, a true beacon of hope and change in the PAD community. Please join me in welcoming and congratulating Dr. David Alper, esteemed retired, well, not so retired, maybe retired clinical podiatrist, but still acting podiatrist and tireless advocate for PAD patients worldwide. Thank you so much from the bottom of my heart, Dr. David Alper, for all you do. And should I say, you are also, I am a very proud board member of the Global PAD Association, but this has been a long time coming. The patients have voted. Who am I to deny you of this amazing honor, because it is well deserved. So, Dr. David Alper, you know what? I'll finally let you actually get a word in edgewise, because I'm going to keep going and singing your praises.
Well, thank you, Kim. You've been always so kind to be president of my fan club. Uh, Working with you, working with your patients, working with your friends has really facilitated the opportunity for me to make a little bit of a difference in the world of PAD, both with patients and with access to care. It's really the question of a village working together. And I am just so honored to be a member of this village. And the honor that you're giving me today and that the people that you work with is tremendously humbling and frankly a little embarrassing. But I thank you, and I thank all of you that really have reached out and let me know that we are making a bit of a difference in their lives, their families' lives, their loved ones' lives, and even people that they just know. And this is really what it's all about. So thank you, Kim.
When we first met, I think it was just a couple of years ago, and when we were both invited to speak by GE for the opening of their documentary about PAD called The
Mm-hmm.
Cut. And you reached out and said, "Hey, I love what you're doing. How can I be a part of it?" And I said, "Okay, well, I would love to have you as part of our online communities. We're always looking for expert support in these communities, not to give medical advice, but to truly be there to provide patients with the right questions, especially to ask their doctor, and to give them a lot of love and support if they're not getting it in their own healthcare communities." And you've gone above and beyond. You not only joined our online communities, but you've been there on weekends. You've taken late night phone calls. You've been a part of Zoom calls with patients who were presenting with limb-threatening wounds to help us to assess them, to help us facilitate getting them to the right doctor. You've made phone calls on their behalf. You've helped expedite care, not only across the country, but around the world. And I mean, there's never any award or any price you could put on the amount of time, the effort, and impact that you have had with our communities. And it's amazing. I mean, story after story. But I'm curious, what really has inspired you to become your passion is definitely driving this. And so, what inspired you to become such a passionate advocate for PAD and these patients?
Well, I think it starts with the fact of being a practicing podiatrist. The number of amputations that I participated in or had to order in the course of my 36-year career was horrifying, absolutely horrifying. And I didn't need the PAD Collaborative and the American Diabetes Association to tell me that this was preventable, all so much preventable. And it was really a matter of helping to empower patients who wanted to be empowered. So many of the people that you work with, Kim, so many of the people that are out there that are suffering from PAD, that are suffering from diabetes, are simply looking to try to help themselves. That they want knowledge, they want direction. And unfortunately, the medical community nowadays exists of 6-minute office visits with their primary physician. And that's not to be critical of my primary colleagues. That's the reality of the world. And so you have patients that don't know enough to know what to ask. And so, of course, they get led down the path of amputation because they truly believe that this is what's best for them. And so, as I continued to practice and tried to give them a little more knowledge, tried to point them in a little more of a direction, I saw that that was making at least a little bit of a difference. Please, Dr., Mr. Smith, go back to your doctor. Ask them to look at your feet. See, is it possible to get referred to an interventionalist? Is it possible to get referred to a vascular surgeon rather than just an orthopedist to remove that foot or that leg? That's the type of thing that made a difference. So when it came time for me to retire from private practice, this is when the opportunity to really be able to work with this came through. Physicians really live their lives as having a sense of relevancy because you spend your entire day helping people, making a little bit of an impact on their lives. You can't shut that off when you stop becoming a doctor. And I would say the same thing is true with teachers, with attorneys, with people that spend their lives helping people. This is now my form of relevancy. So in all truthfulness, Kim, there's a little bit of self-serving here because it fills my life a little bit better by being able to continue to help, to be able to continue to steer them. And I've been very fortunate that I've run into a few people like you that see that I have a small something to contribute and have put me in a position to be able to impart information, to steer people. And I think the biggest thing is to really give them both of my ears and let me hear what they have to say, hear their fears, hear their concerns. Kim, that on more than one occasion, we've had people present something in absolute panic, and it's turned out to be athlete's foot or a blister or something simple. But the truth is, how wonderful to be able to give somebody that type of information too, to be able to put their mind at ease. So why do I do this, and why was I motivated to do it? Because we save limbs and lives, as you so well say, because we empower people to be able to care for themselves and help their own medical care, and because I get a little warm fuzzy every once in a while because I feel like I've done something pretty good.
I love that. I mean, the warm fuzzy it comes with it, but
Yep.
I just wish all the time that we could have warm and fuzzies with every single patient, every person that comes. We want to save every single person. And I'm curious from your standpoint, because there are so many podiatrists out there with different interest levels and different experiences with limb salvage. I would say the majority don't have that education on advanced limb salvage tools and techniques and willingness to go the extra mile to save someone's limb. We had Dr. Haywen Chu. I'm sure you're familiar with him.
Absolutely. Wonderful colleague. Wonderful colleague.
He is our U.S. Podiatrist of the Year, and you know why.
Absolutely.
And he was saying that he really loves those complex lesions. He loves those cases that everyone says are impossible, and he loves to make them possible. That type of mentality is few and far between, and not everyone can have that ability, right? It does take a special personality, but you're one of them, and as well. And I'm wondering, where did you get that? Was this something that you grew up in this mindset of always trying to make the impossible possible?
Okay, you're going to have to tone down the praise a little bit, Kim, or my head's not going to fit on this screen.
It's just truth.
Yeah,
It's
well,
just truth. Anyone who knows me
uh,
knows I don't embellish.
yeah,
I am
well,
really direct.
well, honesty in your profession, I'll grant you that much. Like my colleague, I love a challenge. Doctors are puzzle solvers, and I mean, sure, you like to take a splinter out of someone's foot or sew up a little cut or something like that. But while you hate to have people have challenges, that is the challenging part of medicine is to be, and this is not podiatry. This is medicine across the board. What do you have in front of you? What can we do this? Wow, I've never really encountered this before. And I can give you stories, not even dealing with PADs, everything from plantar warts on up that have been unique challenges. That's what kind of feeds you. It gets the adrenaline going. It really does, because you're challenging your knowledge, you're challenging your innovation. I think that's kind of part of me. I think part of it is, and again, I don't think it's unique to podiatry. I think part of it is what you bring to your medical career. I mean, some people it's a job, and that's not a criticism. It's just some people it's a job, and so they show up at 9 and they do the best they can, and at 5 o'clock they go home. Other people bring it home with them or dig deeper. Um, I am very fortunate that I always enjoy being with people. It's one of the reasons that drove me to medicine, is that I like just being with our fellow human beings. And if you hang out with people enough, I guess you just want to make them more comfortable. But let me add something about the world of podiatry too, if I can, Kim, because you brought up a good point. And it's important for your listeners there to understand this. Podiatrists come in a lot of different flavors. Mm-hmm. My colleagues specialize in sports medicine, in podopediatrics, treating kids, in geriatrics. Some of them do research. Not all podiatrists focus on circulatory issues. There are some podiatrists that are excellent surgeons, but their surgical is focusing on bunions, hammer toes, leg length differences, things along those lines. So you give them a vascular problem, you give them an open wound. This is not their specialty. Why do I mention this? Because when you seek a podiatrist, whether it's through a referral or for your own personal care, you need to make sure that you have a podiatrist that this is what they spend their day doing. I was fortunate enough that this kind of whet my appetite for the type of patients and the type of problems I wanted to treat. But I could have a colleague that has done amazing things with orthotics and shoes and physical therapy and exercise for people in the world of sports medicine that have no idea to treat any of the people that you deal with. And that certainly doesn't make them a bad doctor. It makes them a different specialty. And so it's very important that when you do seek out podiatric care, that you deal with the right podiatrist that has that type of specialty behind them. You and I paired up because that happened to be where I focus on.
Well, I'm glad that you do, because we need more people like you in this field. Can you share a specific patient story that has had a profound impact on your dedication to this cause?
Well, needless to say, I can give you 100, but I will tell you one that brought a lot of sadness to me, and it actually had nothing to do with my care. But I had a patient come in, it's got to be 15, 20 years ago. It happened to be an African-American patient I was dealing with, and you'll hear why that's important in a moment. And unfortunately, by the time they got to me, the gangrene had set in very deeply in the toes. They were wet. They were black. There was no pulses. And so really a transmetatarsal amputation where you take off the entire front of the foot was really no choice. And of course, it's one of the worst parts of a physician's job to look at a patient and say that we've reached an endpoint. This is what we have to do. And the patient looked at me, and I'd say they were probably in their mid-40s. And as calmly as you would be ordering lunch, Kim, they said to me, well, I guess I'm going to look like my grandma now, so it's about time. And I looked at them and I said, really? And they said, Doc, it's a legacy. You know that. This is where we come from. This is just what happens to us. And it's mind-boggling to me, as I did a little bit of a deep dive with my other African American and my other Latino patients, that in some of these cultures, this is just what they expect. That just had to stop. You just can't have people just accepting it as if you're telling them, it's time to cut out sugar. I mean, it really just hit me between the eyes that we cannot have people just accepting it the way that it is. And the problem that goes behind that is that so many of the physicians they run into feel the same way. Well, of course, we're taking off part of your foot. You have diabetes or you have circulatory conditions. And by the way, this is the 21st century. This is not 1912 that we're sitting here in. That just really hit me between the eyes when I heard that type of a story. To think that I was more upset about it than the patient, because they just thought it was part of their future.
Yeah, we've had a couple of those patients. One just last week, African American man who ended up with we talked them down to a below knee amputation. Thank goodness. The doctors all wanted to do the above knee because they still claim that it's better for the patient, it'll heal faster, but they don't consider the fact that they're going to end up in a rehab, they're going to end up in a wheelchair for a lot longer. At least if you do a below knee amputation, the person can get on a knee scooter and still be mobile. If you put them in a wheelchair for how many months in rehab, the legs mirror each other. I've seen way too many of our patients end up with bilateral AKAs literally within months. And so we try to get them mobile as quickly as possible. But here's the kicker of the story, is that when I had someone look at the foot, he said, well, that foot doesn't really look that bad. Why is he even getting an amputation in the first place? Well, the patient had ended up with a fasciotomy. So they tried to go in, tried to open up. It ended up clotting. Of course, they had waited too long. So they ended up with a compartment syndrome and fasciotomy. And I've seen a lot of those where they just want to cut it off. They can be salvageable. We've had quite a few people. And the patient's sister said to us, well, our mom had it. So it's just going to be a matter
Well,
of a time.
and
So we might as well listen to the doctor. He's probably right. Why would we think that taking him to another hospital would just do anything different? He's going to end up losing his leg. We might as well do it now. And it's so sad.
Kim, and by the way, you left out one horrifying, solid fact, that 50% of people that have a limb amputation are dead within 5 years.
Yep.
Which is just mind-boggling to me. When you say we're saving limbs, we're saving lives, that's just not a catchphrase to put on a t-shirt.
Nope.
That is absolutely true. And it comes down to one of the things that I spoke about earlier, and I know you believe in as well too. We have got to empower patients more. This is one of the things that drives me so much, to not just simply say, okay, doctor, I guess you know best, but to be empowered, to ask the questions, to force the issue, and of equal, if not greater importance, second opinions.
Yes.
And I spend so much of my time talking about this to groups of people, to individuals of people, and especially nowadays with things that are available. You must not simply take the plan that you're given right off the bat. Thank you very much, doctor. Can I now take my notes to somebody that is in no way associated with you? I don't want to talk to your partner down the hallway, and let me get a second opinion. And this is not insulting to doctors. Any doctor that's insulted by getting a second opinion, you should run away from like the plague, because everybody misses something. Everybody sees something a little different. And by the way, if they come back with the same diagnosis and plan as you have, it solidifies your thinking and it brings the patient more comfortable with what you are proposing. Patients need to feel. You know, Kim, you talk about 2 generations ago, our grandparents, doctors were gods. You never question anything. If they told you to smear mayonnaise on it and stand on your head for an hour, you'd stand on your head for 2 hours to make sure you did it right. It's not like that nowadays. And why is it not like that nowadays? Because not every doctor can know everything nowadays. Things are so changing so rapidly. Just in the time you and I have known each other, Kim, over 3 years, look at what they can do nowadays with their wires, balloons, and stents. Yeah. The vessels that they can open. They can get into the bottom part of the foot, into the plantar arch. You know, for those of you that don't know the real capabilities of these interventionalists and vascular surgeons, they can pass a wire through a blood vessel the size of angel hair pasta. It is that much that they can do. My life, I can't do that. I don't even begin to know how to do that. But I know that they can do it. And one of the things that we face because of this is ignorance. And it's not just ignorance from the patients, it's ignorance from the physicians that are out there of not knowing what is available and what is possible nowadays. And I know you spend the time and I spend the time not just educating patients, but educating physicians of what is available nowadays. And if you run into a physician that says, oh, your toes are black, you need an orthopedist, they're the best ones to take the feet off, you're not getting the best care because you have a physician that doesn't know what is available in this day and age.
And we had Dr. Craig Walker, who the Cardiovascular Institute of the South is the Global Limb Salvage Team of the Year. And he was on just yesterday in an interview where he said, literally, with the tools and techniques available today, I think we're just about ready to start saving every single person. I would be hard pressed that if a patient came in with, you know, a wound on their toe, now not necessarily wet gangrene, right?
No, I mean, right.
I mean, there is a point where they're in acute limb ischemia, or if they're literally their life is on the line, they've already gone septic, and there's literally nothing you can do. He said, you know, with the deep vein arterialization, where they hijack the vein in the ankle into the foot, they can even take a desert foot where there's nothing and turn it into something. And so if your doctor isn't willing to exhaust all efforts and isn't aware of all of the advanced tools and techniques and isn't willing to, and here's what I say, if they're going to give up on the patient, they need to give up the patient. Before any procedure, you say, you need a second opinion. Before any amputation, unless your life is on the line, second opinion. Get to a second opinion and ask the question, are you a CLI fighter? Those doctors who are CLI fighters know exactly who they are, and they know exactly what that means. Enough said. If they ask you what that means, they're not.
Kim, how many times have you heard of somebody having an amputation that never even had an angiogram, an exam that's been around for decades? Let's forget the new stuff. Let's talk utilizing the basics there. How many times have you heard that happen? And these are types of the things that we're fighting for, you know, for your audience out there. There's so many prongs to the attack that we have here. We need to empower patients. We need to empower physicians. We also need to wake up our legislators to make them realize that there are certain things that are now standard of care or should be standard of care that were not. We also need to pay for this. We also need to make sure that there's coverage for this. But patients need, and I come back to patients as well too, they need to make sure that they're getting everything they deserve, everything their insurance covers, everything that the medical care is available for them out there. And patients don't know. And that's why, again, I say, They need to be empowered to ask the questions, to be made knowledgeable enough to even know what questions to ask. And this is where the weight of my heart comes in. This is where, to global PAD comes in. This is where my colleagues come in, to make sure that patients have to own their disease. Nobody wants to have it, but when you have it, you have to own it. And when you own it, you can control it. And you can control it with knowledge. And you get that knowledge by feeling empowered and making sure you get it.
This is a powerful question for especially women to ask. Why is it that this disease is more prevalent and kills more women than breast cancer? And yet all women at the age of 40 are entitled to a breast exam every year if they need it. But there are so many people out there in which the ABI test, the basic test for peripheral artery disease, isn't covered by insurance.
Which you don't even need equipment for. You need a blood pressure cuff and a stethoscope. That's it. I mean, it's nice to have a Doppler. You don't need it. It's Kim, if you have diabetes, you are given an annual eye exam to check to make sure that your retinas are not changing so you don't lose your sight. A wonderful thing. Somebody woke up, realized that this is important. You can save eyes by simply looking every year to see changes in the retina. Nobody questions it. Insurance covers it. Doctors order it all the time. And yet, an annual foot exam is not covered, is not recommended, is not thought of.
Nope.
Exact same type of thing. I know, my colleagues and I are the gatekeepers that start the whole process. This is what podiatry does. We don't revascularize, but we're the ones that are going to discover it, because you're going to come to me, Mr. and Mrs. Patient, with a wound that's not healing, with skin that's changing colors, with tingling, et cetera, et cetera. And I'm going to look and say, wow, we've got circulatory changes here. But it is not covered if you're diagnosed with diabetes to come see me once a year to see if things have changed from the previous year. Why does this happen? Because our insurers, now you're really getting me on my soapbox, Kim, our insurers and the legislation controls this, still has the mentality of reactive medicine, not proactive medicine. So nobody questions paying for an amputation, which is $50,000 to $70,000 just for the procedure. Forget everything else afterwards. But nobody ever questions that. You don't need prior authorization. Nobody wants to look at your charts to see if you really did it. Nothing like that. And yet, there is no insurance in this country right now, including Medicare and Medicaid, that will cover a $100 visit once a year to look and see if circulation changes are occurring. It makes no sense. And when we go up to Washington and speak to the legislators and try to make them understand this, their only answer is, well, we're afraid of abuse. Your colleagues may do it more than they should. You know what, Mr. and Mrs. Senator? We can do 500 annual foot exams for the cost of one amputation. If we save one leg, and nobody wants to put this in dollars and cents, but healthcare dollar discussions are important. We can do 500 exams to prevent amputations in exchange for one amputation. And they look at you like you're talking in tongues.
I think that's even a better argument than the one I'm going to share, but this one is still a pet peeve of mine, in that there is no pre-authorization needed for any amputation.
Nope.
And yet you need a pre-authorization, which sometimes takes weeks, with so many back and forths, all the way up to a peer review, and they still are denying the attempt to save a leg. I even have a patient right now that is sitting on waiting for a pre-authorization, and they have a wound that won't heal, and they have rest pain at night. And I'm seeing this over and over. And it's really bad. If a patient goes through emergency, we've had this experience. We had one in Georgia just last year. The patient goes into emergency. And the doctor said, well, it's Sunday night. Tomorrow morning, we're going to amputate your leg. She gets on the internet. She finds us. We say, well, do you have any wounds that won't heal? No, don't have any wounds. Okay. What is, your blood look like? Is your life on the line? Nope. Well, if you want to wait, if they're going to wait till tomorrow anyway for the amputation, why don't you get a second opinion? Are you open? So the patient decides they want the second opinion. They leave the hospital. They go to an office-based facility that is just a half hour away, go in there. The doctor says, you know what, I really want to go in and open up that artery. If they say that it's a vascular problem, I'm going to go in and open it up. Preauthorization, absolutely not. Was willing to cover the amputation.
Yep.
Was not willing to cover the opening of the artery.
Which is
It just blows my mind.
Which the amputation is 5 to 7 times the cost of the procedure.
Yep.
So if you are completely cold-hearted and you're simply counting beans, it still doesn't make any sense.
Nope. And I'm getting bombarded with all kinds of questions from our live studio audience. So I think we better get to Douglas. Douglas, go ahead, and then we'll take Marcia next. Douglas, go ahead and unmute and ask Dr. Alper your question.
Yes, sir. Congratulations. It's good to see you again. When you're in Washington, go ahead and run for president. I think you got all our votes. I think you got all our votes, okay?
Yeah, but you don't wish that job upon me, Douglas.
Is from when your career started to where you are today, what is the toughest challenge you still see today in making a difference in getting everybody together on the same page?
I think part of it is not only ignorance, Douglas, but the willingness to remove the ignorance. Too many physicians, as I said earlier, are not aware nowadays of what really is available. I cannot tell you how many MDs don't know what a podiatrist does. You guys treat kids, right? And so when a podiatrist contacts some of these folks, they kind of blow it off. I have actually lectured to groups of interventional radiologists and vascular surgeons to teach them about the training of a podiatrist. These are the people that are referring to you. But by the same token, PCPs have no idea what interventional is. Well, how can you refer to the right person if you don't even know that they exist? And so it's really the ignorance in the medical community and the unwillingness to open up to the possibilities that are here nowadays, I think is one of the toughest things that we face. If you look at a patient and say, I know Dr. Jones says you need to use your leg, but I think I can save that leg. Well, of course the patient's going to listen to you. Why wouldn't they? So I think that it's, and of course, trying to teach doctors something can always be a challenge. We all know that. I think that's one of the toughest things that we run into, is that until we get all doctors on the same page to make them really aware of what's available for their patients, we're going to continue to have patients that fall through the cracks because the patients just don't know.
Thank you.
That's probably not what you want to hear, Douglas, but it's an honest answer.
And that's what we need to hear, is honesty, and not that it needs to be honest spoken today, doesn't it?
Patients need to get angry. They need to be appropriate. I mean, you don't want to go and start busting up all the breakables. But, if someone tells you need to lose part of your limb, you need to get angry. Here's a simple question. Doctor, have we done everything we can to save my leg? You don't need an advanced degree to ask that question. And that they need to be angry enough. And in all honesty, because of culture, because of generations, sometimes just because of weariness, people don't ask that question.
And a lot of times the issue that we have is they end up in the emergency room and they get admitted. The moment they get admitted, a patient feels cornered because at that point, they're stuck.
Yep.
The only way to get out at that point is to check out against medical advice, AMA. And so, and I know I've had some situations where doctors, even if the life wasn't on the line, even if that patient could check out, go a couple of days, and if they decided to do the amputation, they could come back. But instead, they tell the patient, nope, I'm not going to sign off on you leaving. And then the patient says, gosh, if I leave, then what if I go to another hospital? Insurance won't cover me getting my leg saved. And we had a case like that, and the patient ended up losing their leg because they couldn't fight that hospital and they were scared of having a bill. And that is really awful. It shouldn't be that way. And just because a doctor is arguing for their own limitations, this patient shouldn't have to suffer. We see this every single day, Dr. Alper. Just even last week, I had a consult, which we attend a lot of the patient consults with their physicians.
Sure.
And one in particular, it was a brand new patient consult, brand new doctor. He recently got out of fellowship in Indiana. And he told the patient that if he expected any sort of minimally invasive procedure, he wasn't going to get atherectomy. Hands down, it didn't work. It hurts patients, and he wouldn't do it. So I followed up and I said, I definitely understand why you feel that way. There is a contingency of doctors who feel that way, and there are a contingency of universities that won't even allow it in their curriculum. But I said, have you tried it? No. I said, do you realize, that laser in particular is indicated for in-stent restenosis? What do you do if the patient's stent is 100% blocked? He said, well, then I'll just bypass it. And I said, well, does the patient want cuts up and down their legs?
Yeah.
And then what's your contingency plan when that fails?
Do they have the blood vessels to even do it? Do they have the ability to heal from? Kim, one of the things that's so wonderful about you and your organization, now it's my turn to throw praise at you, is the word advocate. I have been waiting for a new profession to appear as a professional advocate, that somebody you hire. Unfortunately, the world robs upon money, but you hire them that come with you from visit to visit to visit to advocate for you. But in some cases, it exists already. And one of the things I've told patients is that when you're at the hospital, you need to ask for the professional patient advocate in the hospital. What is their role? Their role is to ensure that a patient gets everything that their insurance entitles them to. So they're not necessarily medical people per se. The knowledge that you and other people bring about, different types of arthroscopies and et cetera, is wonderful. But it also comes down to, what are you entitled to from your insurance? You have Blue Cross, Mrs. Jones. Do you know that you're entitled to have this? Mr. Smith, you have Medicare, but you don't have secondary coverage. You're entitled to this. And when you're laying in the emergency room and they're telling you you're running out of options, you should look at them and say, I would like to see the patient advocate. I would like to hear exactly what I'm entitled to. Once again, empowering the patient to make sure that they know to ask for everything they're entitled to. And there are people at hospitals that this is their job.
And that's even actually better than myself, because in that situation, that patient advocate can be a buffer between the patient and the doctor to getting that second opinion, which every patient deserves to have.
Exactly.
That patient advocate, it is their job to make sure that you do get a second opinion upon request.
That's right. Underline patient advocate. It's their job to be there for you, not for the physician, not for the hospital, for you. And that is the type of person, not everybody can reach you, Kim, and cloning you, we've been trying, but it just hasn't been happening yet.
No, but the thing is that there are certain situations where we can only go so far. Having someone that's on the inside that we can even go to say, hey, we need to speak to a patient advocate. Here's what we know is possible. And let that person go and fight. Because a lot of times what we find, there are a lot of professional advocate organizations, a lot of really great retired nurses that have gone and started their own advocacy firm. What sets us apart and what we're training our patient advocates to do is to really understand what's possible, really get into the intricacies of these procedures to understand the nuances that a typical advocate or, someone who is a general advocate probably wouldn't know. Because one of the benefits of what we do is we can even tell the advocate in the hospital, because we've seen these procedures, we can tell them, hey, we know a wire can get into that pedal plantar loop when medically appropriate to restore blood flow, but a general patient advocate would not. So we just have to, everybody has to work together. But I think that you have given such great advice that I had never even given and I didn't even think of, is that internal patient relations person, that patient advocate person who can be the liaison for you within any healthcare facility. You do have a right to them.
Absolutely.
And they will make sure you get that second opinion.
If you're laying in the hospital and they're telling you that you need to have your leg amputated and they called orthopedics, well, that's ludicrous.
Yeah.
Call vascular first, and an advocate will make sure that that happens. Now, the vascular surgeon may not be the person to remove the leg or the foot if, God forbid, it does need to happen. But that's not the first phone call you make. That's the last phone call you make. And that is where us empowering patients, us giving knowledge to patients, people like you advocating for them, but also the internal advocate, that is part of their job. That is part of their job. And you asked me what drives me to do this. Well, I know you feel the same way. Every time we're successful with this, there's that warm fuzzy again, because you know that you've made a difference in these people's lives, because they can still count to 20 because they got 10 fingers and 10 toes. And that's the beautiful thing.
It is. And one more thing on that, the patient advocate within the hospital, and this is important, is that a lot of times you go through the emergency room, for example, and you end up, vascular surgery is the only one on call for that moment for a potential vascular issue. But once you're in the hospital, before you let anyone do anything, as long as your life isn't on the line, you can also say, I know that interventional radiologists and interventional cardiologists may also treat these arteries, and I would like to have a different practice review so I can weigh all options prior to making the ultimate decision. I do have a right to that.
And that, again, is the second opinion. And I'll say it again. Anybody that fights the concept of getting a second opinion should be run away from, because what are they hiding? Or they're just in too much of a rush. They're taking an easy... Listen, amputation's an easy path. You know, a second-year resident can do it. They're not hard to do technically, you know, and they're out of the emergency room, over and done with, next. Where it really makes a difference is when you're willing to go that extra mile. And that's what you need to push these folks for. And that's why patients, again and again, and you know what? If you're not healthy enough to do it, then you have your family member do it. You have a loved one do it. You have a friend do it. You have the patient advocate at the hospital do it.
And we had U.S. Vascular Surgeon of the Year, Jacqueline Majors, on just the other day. And she said she tells her patients before any procedure, go get a second opinion somewhere else, and then let me know what they say. Come back, even if you're choosing not to have me continue to be your care provider. I want to know what they said, because I'm always learning.
Right.
I don't want to be left out. I might not be your choice, but maybe you're going to teach me something that will help another patient.
Maybe I missed something. And the flip side is that the second opinion agrees with me. Well, that not only validates my thinking, but you as the patient are going to feel more comfortable with my decision, because you have two independent people that have no horse in the race with each other.
Exactly.
Coming out with it. Kim, when I used to do bunion surgery, I would send people for second opinions. Not life-threatening at all. But maybe they saw something I didn't. Who knows? And by the way, everybody out there, second opinions are covered by insurance. Those are not questioned. And so it's not a matter of running up another cost. And don't let the people in the emergency room tell you, well, you're going to run up a bill. That's not true. Second opinions are covered by insurance. And that is exactly the way the physician bills it, as a second opinion of an existing condition. So that should not be a reason not to do it. I gave many second opinions and I ordered many of them. And I never, 36 years, never had one question.
Good for you. Marcia, go ahead and unmute and ask Dr. David Alper your question.
Hi, Dr. Alper. Congratulations.
Thank you so very much, Marcia. It's good to see you.
Thank you. I wanted to, before my question, I wanted to thank you because you have answered a couple of my questions and guided me quite successfully. So
Thank you.
Yeah, thank you very much. So earlier you were talking about all podiatrists are not necessarily the same. They have different specialties. And one of my earliest questions for you on the Facebook group was how to find a podiatrist. And you did give me an organization. I still don't have one. Unfortunately, I've never had a wound, but I do have PAD and I know I need a podiatrist. And my primary doctor also referred me to one, but I could never verify that they specialized in P and PAD. They specialized in everything. You know, they were a one foot doctor and a wonder.
That's amazing.
And so, you know, with insurance, it's not like I can just go to 5 or 6 of them and just start interviewing them. And so how do you know that a doctor only specializes in PAD when you're looking for a podiatrist, like a all-purpose PAD podiatrist?
Well, it's an excellent question, Marcia. And I will tell you, not only do patients struggle with this, but doctors struggle with this. I've spoken to many, I was hoping to give you some referrals and we can talk offline to see if maybe I can give you another one. But I've had physicians come up to me and ask me for podiatrists in their area that work with vascular patients. It's not that that's all that podiatrists do. It's a major part of their practice, yes. But even in my career, I treated kids with warts and ingrown toenails and things like that. So, it's not 24/7 wound care. That's the first thing you need to understand. The second thing, and really one of the great ways of checking, is to go online to that podiatrist website. Podiatrists will absolutely put on their website what they do. And when you go to a multi-physician group, and nowadays they're not like me of solo practitioners. I didn't play well with others, so I just worked by myself. But nowadays you have groups of 6, 7, however many podiatrists in one office. Why do they do that? Because everybody has a little something different. And if you go to the practice's website, they will list very often, and again, not unique to podiatrists. I mean, all physicians will do this, but they will list, Dr. Smith spends much of his time in the world of wound care. Dr. Jones is your go-to person for aches, pains, and joint issues. Dr. Miller is the one that's happy to treat your children. So that's the first thing you need to do, is to simply go to the website itself and see what member of the practice actually focuses on wound care.
Yeah, I did do that but I only had a few names that were actually given to me. But thank you. I'll continue that. So,
listen, unfortunately, there are less than 15,000 podiatrists in the entire country. There's not a lot of us. And to make you even more horrified, and Kim, I think you know this, there's less than 6,000 interventional radiologists. There's not a lot of us out there. And unfortunately, there's a lot of what we're calling medical deserts nowadays. And what's even more unfortunate is very often these deserts occur where the incidence of these problems is greatest. You live in a major metropolis like Boston or New York or Los Angeles, you'll have your choice of doctors from here to next Tuesday. But if you live in Cupcake, Mississippi, not going to have that type of variety. And I'm sure you already know that you may have to drive 1, 2, 3, 4 hours. Not everybody drives. Not everybody has a car. What do you do? Yeah. And that's why you get online more and more. And that's going to be my other advice. More and more nowadays, you are seeing people like myself that are giving general advice online and are able to help steer you too. One of the things that I've done, I hope fairly successfully with the weight of my heart, is referrals. Because of my position in the world, if I don't know podiatrists across the country, I know people that know podiatrists across the country. And sometimes it takes a phone call or two from me to say, hey, George, you know anybody in Arkansas that does this type of thing?
Shout out, Dayton, Ohio.
See, now I know a lot of podiatrists in Ohio. I don't know ones in Dayton, but I can find you one. And there's a perfect example. So the second thing I would do is I would literally go online and look for podiatrists that have a presence. And I will tell you, here's the deal. Let's say you can't find one in Cupcake, Mississippi, but you go online and you find that there's a podiatrist who specializes in wound care in Dallas, Texas. So you reach out to them. Dr. Smith, I see that you're the person that I need, but I'm 1,000 miles away. Do you have a colleague that you know in Mississippi that can help me? Most of us know each other because we are so small. And certainly the ones that specialize in wound care know each other. I can sit here and name 100 of them without even straining. I don't know where they all practice, and I don't know one that practices in all parts of the country. But if I don't know, maybe one of my colleagues does. So that would be the second thing that I would do, is to reach out to someone that you know for a fact specializes in wound care as a podiatrist and ask them for a referral. Most of us are happy to do it. It's not a matter of losing a patient, especially if they practice so far away from you.
Right.
You see, I think that's probably another good resource as well, too.
Thank you very much.
And I feel your pain, because you're right. So hope that helps a little bit.
Thank you.
Sure.
And thank you, Marcia.
And it's good to see you.
Go ahead and unmute and ask Dr. Alper your question.
Hi, Dr. Alper. Congratulations on the award.
Thank you so much.
I have a podiatrist appointment next week. I have foot pain on my pad leg, more so while I walk. And while I have mild intermittent claudication in my calf to cause me to limp occasionally, it doesn't explain the foot pain. Bottom by the toes, outside of foot. And this started a couple months ago, although I've had mild foot neuropathy before pad treatment and after pad treatment. And I walk about 6 miles or more a day, every day. I walk through the pain, although some days I rest for a couple minutes and then I continue. What questions should I ask the podiatrist?
Well, the first thing that comes to my mind is to make sure they check that it's a PAD problem and not a mechanical problem. Pain in the foot can also just be caused by your mechanics.
It could be, yeah.
Are you flat-footed? Do you have a high arch? Do you pronate? Do you supinate? Do you have muscle strain? I'm going to guess that you're kind of in my age range. One of the things that happens to people once they get past 55 is something called posterior tibial tendon syndrome, where the muscle that keeps your arch up starts to get weak. And you can not only get pain in the bottom of your foot, it's also, by the way, can cause shin splints.
Well, I get shin pain too, occasionally.
So there you go. So some people feel pain in their shin or their lower leg and say, my God, my PAD is acting up, where it might actually be a shin splint. Now, they may not be the best person to treat a mechanical problem, but they certainly should be able to differentiate between a mechanical problem and a circulation problem. So one of the questions I would ask right off the bat is, are you sure, or do you think that this is a circulation problem, or could it be a mechanical problem? I have to be honest with you. And I'm not diagnosing you, here and now if you're willing to put your naked foot up on the screen, maybe. Please don't do that. But if you're able to walk 6 miles a day,
yeah,
I'm questioning whether or not you have a circulation issue or whether you're just overworking your foot. And this could be something as simple as needing a good orthotic, a good arch support in your shoe, maybe better shoes. I can't
I've
tell.
I've gone with wider shoes. Ironically, I need double E's now, but I guess as you get older, you need wider shoes. Some people do.
Everybody's feet get bigger as you get older.
Right. I'm fine.
But my point being, your question is an excellent one. What to ask the podiatrist? The very first thing is I would say, tell them exactly what you told me. I have this PAD pain in my leg. I've been diagnosed with PAD, but I'm walking 6 miles a day and I have this pain in the bottom of my foot that sometimes goes up into my leg. Could this be a mechanical problem? And that's exactly how I would phrase it. When you go to the doctor, and I used to tell my patients this all the time, bring a bag of shoes. Let them see what you're wearing every day. And this is advice to everybody out there. The first time you see a podiatrist, listen, we're only as good as the equipment we use. Nobody walks barefoot throughout life anymore. I cannot tell you how many people I cured because they're wearing a shoe size of a size too small, or they're wearing their shoes for 3 years because they're too cheap to get new ones. Okay. You fill a bag of shoes with the shoes you take your walks in, which you get up in the morning in, which you go to a hot date on Saturday night in. Let them see what you're wearing, and don't bring them something brand new. Bring them something you've been wearing. Make sure they see the socks that you're wearing, because if you take off your socks and you've got a deep ring around your calf because you've got swelling in your legs, well, your socks are cutting off part of your circulation, but they're also pulling on the tendons. And something as simple as socks that are too tight. And you're going to say to me, well, wouldn't I feel that? But you just finished telling me you've got some neuropathy. No, you're not going to feel that. So you bring the socks you normally wear, you bring 3 pairs of shoes that you normally wear, and let them see exactly what you're working with your feet when you do all this. I'd put $5 on the table that I bet your problem's a mechanical problem when it comes to your feet.
You're not the first doctor to say that, and I'm leaning more and more to that. I did wear compression socks.
Okay.
Prescribed also, but I gotten away from that because they caused more pain recently than normal socks. So,
well, but here's the deal. Compression socks also come in multiple flavors. Right. You can get, they have different strengths. They're measured by millimeters of mercury. And maybe you were wearing them too strong. Maybe they were too small. You just said your foot's gotten bigger. Maybe you need bigger socks. The point of the story is that everybody should be checking their equipment to see if you're walking 6 miles, you may not necessarily need compression socks when you're taking those walks.
Right.
You may want to wear them when you're watching TV at night. Mm-hmm. But if you're walking 6 miles, you're pumping away like crazy. You don't need a compression sock to do that extra pumping for you. Bring your equipment with you. Let them see. You know, Douglas mentions wool socks. Wool socks are great for some people because they really keep you nice and warm. Of course, not everybody can wear wool. That can be irritating, which could be another story. So once again, don't just assume wool socks are good. But the nice thing about wool and cotton socks is they really breathe. You know, you don't want to wear 100% synthetic sock, which, by the way, very often compression socks are. They can be 100% nylon because that's what creates the compression. I mean, I can go on for hours about equipment.
Right.
Come back again and simply say, bring those shoes, bring those socks, give them the possibility that this may be a mechanical problem. It'd be a wonderful thing if it is.
Yeah, I agree.
Not only your foot not in danger, but mechanical problems can absolutely be solved.
Yeah, I have no wounds or anything like that. I mean, my foot's a little red, but knock on wood, yeah.
There we go.
Thank you, Dr. Alper.
Dr. Alper, do you mind one more clinical question before we do our final speed round?
I'm right here with you, Kim. Go for it.
Okay, Douglas, go ahead, unmute, ask your question.
Yeah, I tend to have athlete foot only between my pink little toe and the next toe on my left foot only. And I've been having trouble getting rid of it.
Okay. Well, athlete's foot, first of all, we live in a buggy world. So just like there's nothing a doctor can do to keep you from getting another cold, unless you are extremely good at keeping up with things, you can cure athlete's foot and it can just march right back again. So the question number one is, where are you getting it from? Well, part of it is just part of the normal flora of the world around us. Part of it may be what you're doing. So what is it? An athlete's foot, of course, is fungus. What are funguses like? Fungus is like warm, dark, damp places. Certainly describes the inside of a shoe. Not very pleasant to think about, but that's what fungus is like. So I tell all my patients, while you're treating your athlete's foot, before you go to bed at night, you take the shoes you wear, you put them in a garbage bag, and you put them in the freezer overnight. Now, I know that sounds a little odd, but that will kill anything living inside your shoe. You don't want to put Lysol spray or bleach inside your shoe because that's just going to sit on your skin all day, which is definitely not a good thing to do. Grandma back in the 1800s would leave their shoes out on the front porch in the winter. Guess why? Because that killed anything that was inside your shoes. So that's the first thing to do. The second thing is it's really best to not wear the same shoes day after day after day. Because when you wear them all day Monday, you take them off Monday night, and you put them on Tuesday morning, they're not dry. They just have not dried out because your feet sweat, because everybody's feet sweat. So to have a pair of shoes for Monday, Wednesday, Friday, and a pair of shoes for Tuesday, Thursday, Saturday is another good preventative measure. Then you want to start breaking out the athlete's foot powder. Now, athlete's foot powder is not good at curing athlete's foot. I don't care what the commercials say, but it is very good at preventing athlete's foot because it creates an environment that's hostile for new fungal infections to start. So before you get dressed in the morning, you put athlete's foot powder between all your toes, and you can even throw a little bit inside the shoe. And that creates an environment that's not going to allow for the fungus to grow. All these type of preventative things are lifetime things. You don't do it for 6 weeks and say, wow, I haven't had athlete's foot for 6 weeks. I guess I'm cured. Well, you're definitely cured of that batch of athlete's foot, but they're still out there waiting to get you because you taste good. And by the way, that's the other piece of this, Douglas. Some people taste good when it comes to funguses. I will tell you, I was an athlete. I'm a big guy. I sweat, all this other things. I have never had a case of athlete's foot in my life. I've never had dandruff. I've never had jock itch. I must just not taste good to funguses. You do, for whatever reasons. I will tell you that people with diabetes, when their sugar is off, funguses absolutely like that. And I have seen patients with blood sugars that are high, consistently high, and they develop athlete's foot and jock itch and dandruff and all the other funguses that like to live on us. But there are frankly just some people that you just give a good home. And so it's a continual thing. The final thing I will tell you is if you have a really stubborn case that just doesn't want to give away, first of all, there are prescription strength topical athlete's foot creams. Most of the time, the stuff in the drugstores, Lamisil, Tinactin, stuff like that works pretty well. But you can get a prescription strength one. But the other home remedy that I have found that helps a lot with this is vinegar soaks. 1 cup of white vinegar to a tub of warm water. How long do you soak it? I tell people, put your feet in when it's warm, take it out when it's cold. That acid, the acid water, will kill the presence of the athlete's foot. Now, not straight vinegar. You're going to burn yourself. And God, I don't know who gave the idea that soaking your feet in bleach is a good idea. Never, 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 never soak your feet in bleach. It says right on the bottle, keep it off your skin. But vinegar soaks will absolutely cure a good stubborn case of athlete's foot. Won't keep it from coming back again, but will absolutely help clear the playing field. And so you do that. And by the way, you do it for a week. If it clears up after 3 days, you do it for a week. This is a microscopic bug. You don't know that it's all gone. You only know that most of it is gone. So you do it for a full week. The changing of the shoes, the freezing of the shoes, the changing of your socks, that type of thing, that's going to be for you, Douglas, pretty much for the rest of your life. The flip side is it should keep it away.
Thank you.
Really appreciate it.
My pleasure.
We have Marie who wanted to thank you. You helped so many people, and she wanted me to make sure to share with you that you were the only doctor that noticed that her cane was not adjusted correctly for her. And after you adjusted it for her, she has felt so much better. I'm assuming this was last year in Chicago at our in-person event that you kindly let her know that, you know what, you might want to fix that thing to walk better. And it really works. So,
well, Marie, thank you. It really is stories like that that just another warm fuzzy. It's, you ask why you do this. We made such a difference, Kim, with such a simple little act as just looking at a cane.
Yeah.
So thank you, Marie. I'm so thrilled it worked out for you.
And we do have a final just speed round of questions. You've devoted generously so much for your time, but looking ahead, what do you hope your legacy will be in the field of PAD care and especially patient advocacy?
Number one, I would love to be able to be part of the movement that does get insurance companies to be proactive rather than reactive, and not just with PAD, period. We need to pay for preventative medicine. We know preventative medicine works. It saves lives, it saves limbs, it saves healthcare dollars, it saves doctor's visits, it saves hospital beds. I would love to believe that through my and other people's and other organizations' efforts, that we're able to get that dinosaur to change directions in the mud field and make them realize that this is better for virtually everybody. The second thing, I guess, Kim, is what we've talked about for the last period of time. If I feel that I have helped give patients the knowledge and the sense of empowerment to be able to help themselves, then I've done some good, because I can't be in every room, and I can't be on every phone call, and I can't be on every Zoom. And you who work 23 hours a day, 6.5 days a week, can't. I've told you that you can't do this. But if we've made enough of a difference that people can do it themselves a little bit, or their loved ones can do it for them a little bit, then I think we really, truly have made a difference. That for every leg that we've saved individually, if we can make people feel empowered, then we've saved dozens of legs, and we've saved hundreds of lives. And that, to me, would be a legacy that I could smile about. I think that would be a good one.
I think that would be a great one, exceptional one. Okay, our final three, we have 3 different series. Our first series is called Journey to Diagnosis. And I want you to share a case that had you scratching your head about how in the world this patient was not diagnosed sooner and what you wished would have happened differently with that patient. You could even share a story of a patient whom you couldn't believe had other procedures, such as even a spinal fusion, which did not relieve symptoms. And all they needed was for someone to check their pulses, realize there was a vascular problem, and treat that accordingly to relieve their symptoms.
I had a patient who had surgery, had bunion surgery actually, was in their late 40s, and went perfectly normally. And by the way, this was a second opinion. And within 24 hours, this foot turned hot red. No diagnosis of circulation issues. Very typical 40 plus something woman. Foot turned cherry red. Unbelievable pain, burning, itching, migrating up the leg. Could not figure out what was going on. X-rays, did they leave material in? Did they break a tip off a scalpel in? Was there tissue left in? Was there an infection? Could not figure it out. And they were cast. This patient went to a dermatologist. This patient went, I don't know if they went to a vascular, I can't remember, but they were accusing the whole thing of vascular compromise. And they were starting to talk about doing some aggressive vascular care. They came to me and I looked at the wound. And the first thing I said is, why are your stitches still in? We need to open this wound. The surgery had only happened less than a week ago. The wound had not healed. So we got to take these stitches out. Oh, I don't want to do that. I said, listen, we got to see what's going on. If there's something that wants to come out, and very honestly, I need to look what's going on inside. So I took the stitches out and I looked around. I didn't see anything either. And I'm talking back and forth with the patient. And I said, this almost strikes me as an allergic reaction, which is crazy. Tell me the medications you're taking. Did the doctor give you anything unusual? And believe it or not, the patient happened to mention they were allergic to nylon. Now, I don't know about you. I have never in my life run into anybody that's allergic to nylon. But guess what sutures are made of that close your skin? This woman had about a foot of nylon suture in her skin. So they were starting to talk about all this aggressive, invasive vascular work. They're talking about the possibility that maybe this toe is going to be lost. I mean, they're filling her head with all sorts of things. We took the stitches out. Within 24 hours, the foot was fine.
Wow.
Second opinions. Looking out of the box a little bit. I'm not smarter than everybody else, but I had the advantage of everybody else thinking of everything and it not working. So I had to think out of the box. So that was the first one that I had, which was kind of unusual, I would have to say. The other one, again, it's a matter of looking, is that a patient came in to their primary physician and their toes and their foot had turned black. Hadn't seen them for a while, was very concerned of the discoloration, couldn't understand it, everything else. Very long story short, Kim, they sent them over to me. Of course, as soon as I heard black toes and black foot, I said, well, you just come in. I mean, I don't care if we've got patients. Come in, got to see what's going on. Yeah, the dye from their socks had run on their skin. The moral and a little bit of acetone, and I cured their vascular disease. The point of the story is that sometimes people react a little too quickly, get it out of my office a little too quickly. But this is where patients need to be able to feel empowered to say what's going on. It really, truly was. So I know you may have been looking for big stories about all different types of vascular breakdown or surgical breakdown, but sometimes it's really just a simple thing. This person was in a panic over their feet turning black. It was the dye that had run from their socks. And it came off. I called the doctor. The doctor was appropriately embarrassed. You know, why didn't I think of that? Well, I don't know. You didn't. You know, it's as simple as that. Feel empowered.
Sometimes it's just a matter of even just touching the patient. That probably would have been figured out right away. And I always say, even, you know, my mom transitioned because the doctor didn't bother to touch the patient. If they would have touched the patient, they would have discovered she had a bruit in her abdomen, an aortic aneurysm. So touch the patient, touch the patient.
Touch the patient, break out that stethoscope that's hanging around your neck is supposed to do something. Listen for bruits in the neck. Listen, you know, I had a patient once who had a fairly nasty infection in the foot. And I reached behind their knee to check the lymph nodes, and it was hot and warm there. And I started to check their groin, and they looked at me like, what the hell do you think you're doing? You're a foot doctor. I said, I am checking to make sure your infection is not going all the way up. And please note that move the word podiatrist aside. I am a doctor and your doctor. And the patient looked at me and I said, I don't have to do it, but you want to know what's going on. And of course, as it turned out, they were hot in the groin too. So rather than sending them over to a vascular, I sent them to the emergency room, ordered some IV antibiotics. Let's get the infection cured. And then, by the way, we'll start addressing other things too. So you do need to think out of the box a little bit. You do need to touch patients. You can't be afraid to do that. Unfortunately, when you only have 6 minutes of you and the patient in the room, and you're spending 3 of them looking at your computer screen to make sure you fill out all the boxes, it's happening less and less.
And speaking of 6 minutes,
okay,
share 6 minutes that mattered in your career. It has to be, we like stories, so it has to be a defining moment, a true catalyst for change, a spark that may have led you in a specific direction. It could have been a conversation that you had with someone. It could have been a scene in a show or a movie or even a documentary. It could have been a moment where you just witnessed something eye-opening. What were the 6 minutes that mattered?
So I was a surgically trained podiatrist. I went to podiatry school. I went to residency and spent 2 years doing surgical training. Now it's 3 years. I did a fellowship for a year afterwards. I was a surgeon. And I would do, for 20 years, I would have 100, 150 cases a year. I mean, I did other things too, obviously. And I was realizing that I wasn't getting, for me, the same satisfaction that I was getting doing the type of things that you and I are talking about. I found much more satisfaction in getting a wound closed, helping patients prevent wounds, helping them get their diabetes under control, get them to stop smoking. That alone is an accomplishment. And as I continued to do it, and I continued to look at what I was spending my days with and what type of patients I was working with, I actually did speak to a mentor of mine, my residency director back in Kansas City, a wonderful gentleman, and that's Michael Naklis. And everybody's got somebody that guides their career. I'm sure somebody in broadcasting helped you with yours. And I talked to Mike about it. And I said, you know, Mike, I'm a surgeon. I was trained as a surgeon. This is what I've done. But, you know, I'm really starting to feel. And he kind of laughed. And I'll never forget this conversation. And he said to me, you're looking for permission to give up surgery. And I'm giving it to you. But what are you going to do? And I says, I'm going to spend my time with the stuff that really seems to make a difference within me. I'm going to devote my time to wound care, to diabetes, to the types of things that, to me, is where my time really should be spent. And he's like, well, then what the hell's stopping you? And 3 months later, I closed the surgical part of my practice. I handed my surgery over to colleagues who were in my area. I put it out there to the physician world that this is what I did. And I will tell you that the last years of my practice were my best. People that knew me would say the same thing. I found it the most gratifying. I found that I made the greatest impact. It was so much more satisfying to be able to look at somebody and say, you know, your wound is closed, we're healed, let's move forward, than to say, okay, Mrs. Jones, you can wear your 2-inch bumps again. And there's nothing wrong with that. And again, a lot of my colleagues do it. But the epiphany for me is when I was able to look within me and see that maybe this was my calling in the world of medicine. And it was that, I don't know if it was a 6-minute conversation, but it was that conversation with somebody who I respected above all others in my profession. And he's not, top of the food chain in the world of education. He's just a guy like me that practices. But because of the conversation with him, I made the decision to focus on what I felt I could make the greatest impact and meant the most to me. So I hope that answers your question.
Well, you certainly have had such an amazing impact throughout your career, and you continue to do so. And we appreciate you so much. Dr. David Alper, the Global Patient Champion of the Year. We recognize him for his exceptional dedication, his unwavering commitment, and transformative impact in the lives of PAD patients worldwide. Thank you so much, Dr. David Alper. Well deserved. And from the bottom of my heart, we appreciate all that you do and the love that you have for every single one of the patients whom you touch.
Well, and Kim, thank you for trusting me with your most prized possessions, the people that come and look to you. And to everybody out there that has shared themselves with me and have asked me questions, either today or before, I can't thank you enough, because you are trusting me with your most prized possessions, which are your bodies and your health. And that type of trust just cannot be measured. So I thank you for putting your faith in me with that and letting me help you get to a healthier, better life. And